Um, yeah, logistics slide. Thank you. So for everyone using Zoom, which is all of us today, please note you can use the chat function to ask questions. Your message will be sent to the seminar organizer and relayed to the speaker. Please use the link to access the transcript. We do have closed captioning provided. You can use that link to get to it. The seminar is being recorded. If you have any technical difficulties, please contact Jamie Trumbo. Her email is right there on the screen. And with that, just a quick overview of upcoming seminar speakers. Obviously, today we have Dr. Neitzel from University of Michigan. In February, at the end of February, we have Dr. Ava Dugoff, who's a senior health advisor to the U.S. Senate Committee on Finance. And then in March, we have Kath McMahon, who's a professor from audiology from Macquarie University. Please note for March, the time, due to the time difference between Australia and the United States, that one will be held at 4 p.m. Eastern time. Also, quick plug for April 25th, our Cochlear Center Research Day. We'll be doing presentations and updates from faculty members on their research, trainees with posters, and quick presentations on their talks or on their recent research. And our keynote speaker that day will be Natalie Phillips, who's a professor of psychology from Concordia University. Registration information will be coming out soon. With that, I'd like to introduce our speaker today, Dr. Neitzel. Dr. Neitzel's talk today will be the Apple Hearing Study, New Approaches to Evaluating the Relationship Between Sound and Health. Dr. Neitzel is a professor of environmental health sciences and global public health at the University of Michigan School of Public Health. He's published over 125 peer-reviewed manuscripts, not too shabby, focusing on exposures to and impact of noise and other occupational and environmental hazards. He's particularly interested in incorporating new methodologies and exposure sensing technologies into research, and has a strong interest in translating his research findings into occupational and public health practices. Dr. Neitzel is chair of the ACGIH Threshold Limit Values for Physical Agents Committee. He's a fellow of the American Industrial Hygiene Association and has been a certified industrial hygienist since 2003. This is very fun for me. I will say that I saw Dr. Neitzel speak when I was a fellow at the National Center for Rehabilitative Auditory Research over 9 years ago, and his talk has always stuck with me. It was a fantastic talk. I know it's not going to be the topic of today, but he's done amazing work on thinking about just noise in cities and what that does to our everyday life. I highly encourage you to check it out. And with that, I will turn the mic over to you, Dr. Neitzel. Thank you.
Thank you so much, Nick, for the kind introduction. Great to see you again, though I think we're both at new locations since that last talk. I'll also say I am so sorry that I'm not able to be there in person with you all today for several reasons. One, I would just love to come and see the Cochlear Center. Two, I don't know if you can see out of the window behind me here, we're in the middle of like whiteout conditioned snowstorms here in Michigan, so I'd rather be just about anywhere else right now, frankly. Nevertheless, thanks so much for bearing with me through a Zoom presentation here. I'm very much looking forward to telling you all about some things that we've been up to with the Apple Hearing Study. One other quick comment, I'm going to keep an eye on the Q&A, so if folks do have questions, please do post them. I'll try to take them as they come in, and we'll do my best to stay on top of that. So let's go ahead and dive in here. I wanted to begin today's talk with what might be review for many, if not all of you on the line here, but I think some of these statistics just bear repeating. So what do we know about hearing loss globally? Well, the World Health Organization, the WHO, estimates that there's somewhere in the neighborhood of 430 million people worldwide who have a moderate or greater hearing loss. So again, perhaps preaching to the choir, but I suspect many of you recognize there's just not that many other public health burdens out there that have this great an impact on humanity. Now, we know from over 100 years of research in the workplace, and in fact, if you go back even farther than that, I would argue that we've known for 1,000 years that chronic workplace noise exposure can and does in fact lead to noise-induced hearing loss, of course, permanent and irreversible noise-induced hearing loss. We know that the best estimates available to us suggest that about 20% of those 430 million hearing loss cases that the WHO estimates are actually due or attributable to workplace noise. Now, you may also know that chronic noise exposure outside of the workplace, or what I'll call environmental or non-occupational noise exposure, may also be associated with noise-induced hearing loss. However, while we have very definitive data with regards to occupational noise and hearing loss, the data for non-occupational or environmental noise and hearing loss are much more sparse, and the relationships are much less well understood. So that generates, of course, research opportunities for folks like you and me. I wanted to, before we actually dive into any details about the study here, just put the study in the context of environmental health sciences, which is my background and training. So the exposure disease model that I've presented for you here is a nice, I think, pretty simple and intuitive way to organize our thoughts about how to understand any association between an environmental hazard and potential health outcomes in people. So the exposure disease model here begins with a source, the point at which a hazard, in this case noise, originates in the environment around us. Then we have to think about the movement of pollutants. So how does that noise, in this case, travel through the environment away from the source? When that hazard, noise in this case, comes into contact with people, then we have human exposure. And exposure then leads to dose, as you see here in orange, dose basically being how much noise is getting into our body and potentially capable of causing harm. And then that dose ultimately leads, unfortunately, to adverse health effects. Now, I'm going to focus on hearing loss for the purposes of this talk, given the audience. But I do want to recognize right up front here that noise has been very strongly associated with non-auditory health outcomes, things like hypertension and stroke and mental health and cognitive impacts and injuries and annoyance and sleep disturbance, such that hearing loss may only be the tip of the iceberg in terms of the overall public health burden of noise. But to bring it back to the exposure disease model here, really we need to evaluate each and every step in the exposure disease model for us to fully be able to understand the associations between environmental hazards and health impacts. So I want to highlight a few of the knowledge gaps that are facing us as researchers, or I should say knowledge opportunities, perhaps. One, I imagine everybody on the call here recognizes the need that we have for more cumulative and more long-term data on exposures to noise from the environment and non-occupational activities, as well as to music, which we'll talk about more. Also, of course, to understand the impacts on our hearing from noise and environmental sound and music. And third, to understand beyond just the hearing loss impacts, what are cardiovascular and stress impacts associated with noise and music? So we have some suggestive data, but really not enough to answer these questions. So, in other words, the data say that we need more data, which I'm pleased to be able to talk to you about the Apple hearing study. Now, when we talk about these knowledge gaps, historically, all of those types of data I just mentioned were pretty difficult to collect. So there are certainly studies out there that have done very high quality exposure assessment. There are other, I would argue, more studies that have done very high quality evaluations of health outcomes, including hearing impacts. But I'll submit that there are very few studies that have high quality evaluations of both of those aspects, both exposure and health. Now, when we think about understanding exposures to sound that might occur across your and my 24-hour days, historically, we've divided those days up into two segments and assessed each of them individually. So the first segment is the one that we're all in right now, which is occupational. And so, historically, we've considered a nominal 8-hour occupational exposure or a workday. And we have equations available to us to compute, well, what was the average noise exposure over that 8-hour period? So this is well-established industrial hygiene practice. But what do we do with the rest of our day? Well, those other nominally 16 hours per day are spent non-occupationally. And we can certainly come up with an equation, a very similar looking equation, to account for those 16 hours a day that includes sleep and recreation and eating and commuting, etc. One thing, though, that we haven't done a very good job at all of considering in the past is music exposure. So we have to recognize that music can be overlaid on top of both of these exposures, occupational and non-occupational. And we really need to add whatever exposures people are getting to music to those other exposures to achieve essentially the most accurate estimated exposure possible. Now, when it comes to noise and every other environmental health hazard out there, of which there are a seemingly infinite number, there are really three equally important components that we need to consider. So the first is intensity, as you see here, or in noise exposure parlance, the sound pressure level. So essentially, how much of this exposure is there? The second key concept is frequencies, by which I mean not frequency on the frequency spectrum, but rather frequency with which exposure to sound occurs. Is it every hour, every day, every month, every year, etc.? And then third, and equally important, is duration. So when this exposure does occur, how long does it last for? Again, is it hours? Is it minutes? Could even be seconds for some exposures. So really, we need information about how much of the agent, how often the agent exposure occurs, and how long those exposures last before we can truly start to understand exposure for any individual or for a population. And I will say, knowing something about one or two of these things is not sufficient to understand exposure. We can't just know how loud something is or just know how long it lasts or how often it occurs. We need all three. And for non-occupational exposures and music, we have substantial uncertainty about all three of those parameters. Now, a second gap we have relates to hearing evaluation. So there have been a number of short-term studies on non-occupational noise and noise-induced hearing loss. Oftentimes, those have very good measures of hearing and maybe include personal noise measurements. But the generalizability for most of these studies to longer-term impacts is simply unknown. There have been, on the flip side, a number of long-term studies of non-occupational noise and noise-induced hearing loss. Those more chronic exposure studies often have very good measures of hearing, but often feature very poor measures of exposure. Additionally, long-term studies, and perhaps I don't need to say this, but I'll just note it anyway, are rare because they're very expensive and logistically challenging. And then any studies of music and noise-induced hearing loss are rare. Those that have been done often have pretty good measures of exposure, as well as changes in hearing, but don't typically have good measures of long-term exposures to music. And then finally, when we come to cardiovascular disease and stress, there have been a number of both short and long-term studies of noise and cardiovascular disease. They share many of the shortcomings that I've highlighted already. I'll highlight there have been virtually no studies on the impact of music on cardiovascular health as well as stress. And so you might imagine, well, is music of a certain intensity and duration and frequency better for the human cardiovascular system or for stress than a similar noise exposure for industrial noise, for example? Is it worse? Again, we don't really have sufficient data to answer that question. So really, all of this is my way of saying what we need are more data. We need high resolution and long-term prospective data on personal level exposures to both environmental noise and sound from headphones, which is something we historically simply have not been able to assess, but also high resolution long-term data on impacts on hearing, both hearing loss and tinnitus, again, from those non-occupational exposures that we all have. And so at this point, 9 slides in, it's my pleasure to introduce to you the Apple Hearing Study. This study was launched in November 2019 and is scheduled to stretch through 2024. The study is registered at clinicaltrials.gov, as you can see on the slide here, and we also have a website that I'll encourage you to visit that we host here at the School of Public Health. So let me lay out for you an incomplete or partial conceptual map of how we envision the aspects of human life that we're trying to connect to hearing health including both hearing loss and tinnitus. So as a shocker to no one coming from an industrial hygienist, someone who focuses on workplace health and safety, we know that occupational noise is absolutely linked to hearing loss and tinnitus risk, but we know that that association is moderated by use of hearing protection or lack of use of hearing protection for many people. Now, as I've said, there is some data, but not nearly as much linking environmental noise to hearing loss and tinnitus. Again, that's going to have influence from use or non-use of hearing protection. Now, we also hypothesize that location within the United States, and this is a US study, is going to link to and perhaps predict environmental and maybe even occupational noise as well. And so location data that we have from our participants are based on self-reported zip code. We also have reason to believe that zip code may, geographical location in the US may be linked to how loud people listen to headphone audio. You might imagine someone in a very dense urban setting cranking the volume up compared to someone who's out in a quiet rural environment. And then, of course, we know there are other factors that are indisputably linked to hearing loss and tinnitus, things like age and gender and family history of hearing loss. Also, the predisposition to having temporary changes in hearing after short-term exposures, as well as socioeconomic status. So the Apple Hearing Study has a couple of objectives that we laid out. The first is really just to understand what are people's typical headphone sound exposures and how do those exposures relate to hearing health. Also, for our participants who are using Apple Watches, we want to understand the relationship between environmental sound exposures measured by the watch and how those exposures, again, relate to hearing health and stress. And finally, our study does include a mild intervention. We're trying to understand how participants interact with and how their behaviors might be changed by access to and reminders to check information about their own exposures. So how's the study work here? I'll give you a quick overview. Participants download something called the Apple Research app, and that's the only way with which they interface with the study and the study team. So as someone who's done mostly prospective data collection in his career, this was a real change for me, having a completely virtual relationship with our participants. But it's worked out quite well, as I'll describe as we go. Now, the moment that participants volunteer and are enrolled in the study, this is absolutely an opt-in study, they get randomly assigned to one of two arms. So 40% of our participants are randomly assigned to the basic arm. These folks have access to everything that any of you do who aren't in the study but have an iPhone. So you can review on your phone your headphone exposures, your environmental exposures, if you have an Apple Watch. That information is all absolutely available to you. And then the other 60% of our participants are assigned to our advanced arm. And so these folks actually get notifications to go into their health app on their phone and review their data. They are also prompted to take a survey and a brief tone audiometry test each time that they have a loud noise exposure. So I'm just going to pause here. I see a question has popped into the chat from Margaret. Will we be capturing with location information how much forms of other pollution can also affect hearing? So that's a great question, Margaret. Our study here is designed to get most detailed information on noise and sound exposure. But because we do have approximate geographic location, we will be able to assess, for example, some forms of air pollution that very commonly coexist with noise. Now, I will say most of the very well understood ototoxic chemicals are not likely to be present sort of environmentally. People are more likely to get that from their workplace. So we also are asking about people's work. So great question. I hope that at least somewhat answered it for you, Margaret. Rolling a little bit further into what folks are doing, we have people doing a number of different activities as part of the study. So they are asked to complete scheduled surveys at baseline when they enroll, and then every 3 months or so afterwards. And so from these surveys, we get information about demographics, about different types of behavior that might influence their exposure, also about their perceptions of how much noise they're exposed to and their perceptions of their hearing as well. Also factors like occupation, family history, etc. They have a scheduled hearing test, actually several that they take at baseline, and again, approximately quarterly after that. They take via their iPhone and Apple hearing listening devices, so AirPods, EarPods, etc. They take a pure tone audiometry test between 250 and 8,000 hertz, and also complete a speech and noise task. Those who choose to share with us their headphone audio, and again, I want to emphasize this is all opt-in, voluntary information sharing. People can pick and choose what they do or don't share with us. Those who share their headphone audio exposures, they share that continuously, not what they're listening to in any way, but the level at which they're listening to it as determined objectively. And so that comes from their phone, and from that information, we know how long they were exposed and how loud. And then for participants with Apple Watches, we get information about environmental noise levels around them, also heart rate variability, and information about exercise. And again, that's shared with us continuously. So looping back around quickly to the exposure disease model here, again, we're trying to understand people's environments, where they live, the type of setting they live in, dense urban to exurban. So the surveys give us some information about their sources of exposure, as well as how they give us the ability to infer how noise may move through their environment. We get human exposure data from measurements of environmental noise, and we get dose estimates, so sort of how much noise or sound is getting into their body from those headphone measurements. And then finally, through a combination of surveys and hearing tests and heart rate data, we get information about potential adverse health effects. So again, I just want to sort of close the loop here and show why we're doing the measures that we are in terms of understanding exposure disease relationships. Now, you've probably figured this out already, but just to emphasize further, we're faced with some very complex analytical challenges with this study. So we've got lots and lots of data streaming into the cloud, multiple data streams that are all time synced. That's the good news, but they're being shared with us at different temporal scales. So on the left here, you can see somewhere between monthly and yearly, we're getting information from surveys and from hearing tests. And then on the right hand, we're getting data every minute that folks wear or use their devices on environmental sound as well as headphone audio. So trying to match things up at a yearly cadence to those that are flowing in even at sub-minute levels for some data points is challenging. Also, again, probably preaching to the choir, we have to consider the potential lag or delay between when folks are exposed and when we might start to see impacts on their health. Now, I wanted to just raise this question. This is one example of, as I think of it, a crowdsourced or citizen science study where people are sharing with us information that's being collected during their daily lives with the devices that they're carrying around with them always for most of us. And so I just want to emphasize with this and any other study, we have to ask, well, how valid are the methods and the instruments being used? So I'll say, as a scientist, crowdsourced data collection is hugely attractive because it's a very quick way to get to big data across many people. You know, if you think about data flowing in from thousands of participants at minute or sub-minute intervals, 24 hours a day, that quickly adds up to an enormous data set. But I will just emphasize that the data are really only as good as the methods. And if we're not collecting the data or measuring things very accurately, what we can do with that data is very limited. So I'm not going to describe validation efforts for across our study, but I'll mention at least some things that increase our confidence with regards to how we're measuring sound and noise. So for sound, some of you may be aware the World Health Organization and the International Telecommunication Workers Union teamed up several years ago to establish this standard that you see on the left here, safe listening devices and systems. So this is essentially a technical standard that tells manufacturers like Apple, how do you program a phone to serve as a dosimeter for measuring headphone audio? As I mentioned earlier, historically, that's been something we simply couldn't do or couldn't do on a practical level at scale with potentially thousands and thousands of participants. Now we have not only the technology to do this, but a standardized way in which this can be implemented, such that if multiple manufacturers make these or implement this standard on their devices, we should be able to compare sound exposures measured through headphones on an Android device to Apple, to other types of manufacturers. So this is a key step, and I have to thank the WHO and ITU for this. Now, I'm going to talk to you for a moment here about our validation efforts on the Apple Watch. I will highlight, Apple, of course, has done their own product validations, but we are publishing independent evaluations done in our research lab, again, just to verify and share with folks how well do these devices perform. So for this particular experiment, which is under consideration right now for publication, we tested 8 Apple Series 6 watches on running the latest watch operating system. And to measure sound levels on the watch, we just used the default noise app. Again, that's something that's available for everyone who has an Apple Watch, regardless of them participating in the study or not. And these measurements are made using the microelectrical mechanical systems microphone that's built into every Apple Watch. The work I'm going to describe here was actually done at the acoustic testing facility in Cincinnati that's operated by the National Institute for Occupational Safety and Health, our collaborator on this study, and was done in a reverberant chamber, as you see. So our real question here is, if we put a watch in an environment with a known sound pressure level, how accurately does it measure that sound pressure level? And so we exposed this fleet of watches to pink noise, and we increased the sound pressure level in 5 decibel increments from 65 to 95 dBA. So basically, we tested these watches at 7 different noise levels. We wanted to look at overall A-weighted sound pressure levels, but we also did some octave band specific analysis. So you can see we looked at the octave bands listed here and presented noise at 70, 80, and 90 decibels in each of those octave bands. Again, just to evaluate the performance of the watches. Now, the sound levels we measured in the measurement system that was built into the booth that we use, so you can see the details here. We also actually compared to a type 1 sound level meter that we put essentially adjacent to the watches, just as a secondary way to evaluate their accuracy and precision. So what we're looking at here, these are the different devices that we tested from A1 to A8, our assigned numbers for them. And then the data points on here are the average difference between each watch and the gold standard sound level meter. And the whiskers are the 95% confidence interval. So a couple things to note here. Sorry, my twitchy mouse has betrayed me again. So you'll see on average, there was a difference between the sound level meters and the watch of a little more than 3 decibels here. But you'll note that essentially all of these watches are overlapping in terms of their 95% confidence interval. And so the good news takeaway here is that we didn't find significant differences by watch. A worst case scenario would mean we need to know exactly which watch you're wearing on your wrist. These watches all appear to be interchangeable from an accuracy and precision perspective. That's great. Now, these are the differences between broadband pink noise that we presented to the watches and the gold standard sound level meter measurement. So this is a summation of a little over 11,000 measurements that we made, again, at noise levels going from 65 to 95 dBA on the y-axis. Now, on average, the watches were 3 decibels, 3.4 decibels lower than our reference microphone or our gold standard. So that's why these box plots are all slightly offset from 0. But the good news is, again, we'll see very high levels of consistency here. So if you look at the box plots here, they're very tight boxes, essentially all at right around 3.5 decibels different from the reference microphone. We did see some outliers here, but actually very few, and the outliers tended to be greatest at the highest levels of 95. But again, the vast majority of the data were clustered quite closely to the sound level meter. So that's good in terms of good precision and repeatability. I'm going to move quickly over this graph here. It's a lot to take in, but again, we're looking at the octave bands that we tested the watches at, and we're looking at the sound pressure levels where we did the testing, 70, 80, and 90 decibels. And I'll note that the biggest differences between the watch and the sound level meter occurred at 125 hertz. So we see sort of the biggest offset from 0 to where the Apple Watch data were. Those differences declined down to 1,000 hertz. The watch is actually read a little bit higher than the sound level meter at 2,000 and 4,000 hertz, and we're almost spot on at 8,000 hertz. So we do see some differences, again, down at the low frequencies that tend to be largely discarded when we use broadband A-weighted levels. And again, basically very encouraging results here. So when I compare these watches to smartphone apps that we've tested in my laboratory and in other published studies, these watches appear to be more accurate than just using an uncalibrated smartphone app and your smartphone microphone. The watches weren't quite within the plus or minus 2 decibel tolerance that would mark an ANSI type 2 sound level meter, but they were pretty darn close. And more importantly, the measurements were consistently lower than the sound level meter. So they showed good precision. In other words, they're slightly biased, but bias is something we can account for in our statistical models. So that's just to give you, again, a taste of the type of work we're doing here, again, to publish and verify that these instruments and tests work as we hope they will, or where they differ from gold standard tests, help us understand how they differ. Sorry, Abby, I think I missed your question for a minute here. Are the participants already Apple product owners, or were we supplying these devices? Boy, I wish we had the kind of funding that would let us give Apple Watches and phones to people. No, these are existing Apple users who are opting to volunteer into this study. So you bring up an excellent point. This is a limitation I'll go into later, but one of the concerns we have is, are people who can afford an Apple Watch and a late model iPhone potentially different from the general public? And I think they probably are, particularly, as you say, due to socioeconomic status. So I'll come back to that point in a few minutes as well, but great question, Abby. So now, again, shifting from methods into some preliminary results here. And again, I will say we're not even halfway through the study, so I'm couching this as preliminary, even though we've got a lot of data already. So to date, we've collected about 280 million hours of environmental noise and about 20 million hours of headphone audio. So 300 million, give or take, hours of sound exposure data. I think this is now by far the largest data set on noise that's ever been compiled. We've also collected a total of about 200,000 hearing tests on our participants and more than 175,000 surveys. So as I said, this starts to feel like a big data study where we've got millions of hours of exposure data and hundreds of thousands of health outcome measurements. And one of the things these data have allowed us to do is to start asking questions like, well, gosh, do environmental sound levels or headphone audio levels differ across the United States? And so you can see here, both these maps are just showing the week of January 1st, 2020. And you can see, in fact, there is a gradation where not every state is listening at the same level to their headphones or exposed to the same level of environmental sound. Furthermore, because we're collecting these data longitudinally, we can actually start to ask questions like, well, gosh, how do sound levels change over time? And so you'll notice this is right at the outset of the pandemic as it reached the US. Hard to believe that's now more than 2 years ago. So I'm just going to play this video for you here. Every time the colors change, we're moving a week ahead in time. And so many of you will recall that March was when the lockdown orders went into effect in the US. And you saw just a moment ago, all the colors went light blue. People's environmental sound exposures went down significantly as a result of lockdown orders. I'll talk about that more in a moment. And then you can see the steady march of time forward here through July, through summer of 2020, and into early fall. And the noise levels start to return to where they started, but didn't quite make it back there. And I'll show you another graph in a moment of what that looks like. Another thing we can start to ask is, gosh, well, what do different days of the week look like for our participants? And so you can see the days of the week here. This is starting again back in January 2020. Each time the bars change, we've got a new week going on. So through February, we can see Saturday and Friday and Sunday tend to be the loudest days of the week. And then the lockdown orders go into place. You can see that dramatic shift where all days become quieter and effectively all days become the same. I don't know if any of you remember the lockdown period, but it was like, I'm not going to work, I'm not going anywhere. And in fact, we see in the data that those day of the week specific changes essentially were washed out with the lockdown orders and started to creep back in the months afterwards. Again, this is not something we set out to measure, but we were in a great place to be able to do so. So when we compare the levels that we've measured to the guidance that's out there to protect hearing, we found that about a third of our participants have average daily noise exposures that are above the WHO limit. WHO wants you at an average of 70 dBA over any 24-hour period or below in order to essentially eliminate any possibility of noise-induced hearing loss. We found that about 44% of our participants have worked now or in the past in a loud workplace. Almost 2/3 of participants report not using any hearing protection when they're in high noise. And about 10% of participants are over what the WHO considers to be a safe limit for headphone audio. And this is not described on a daily basis, but rather as a 40-hour moving window of which we want to have people at 80 decibels on average over that 40 hours or below in order to virtually eliminate any risk of noise-induced hearing loss. I see we've got a question from Moises here. So yeah, please do keep the questions coming. Can hearing vary in a given individual over time? Absolutely. So I don't have data that I'm presenting today, but we do have serially collected measurements of both speech and noise and tone audiometry on our participants. And so we can actually see how those might vary over time. Now, cumulative exposure before the onset of the study, we don't have information. We've asked, for instance, in the survey about how long people have worked in a noisy job, how long they've lived at their current home. This is perennially a problem in epidemiological studies that aren't done on naive cohorts, trying to understand their past exposure. So we will certainly describe their exposure at baseline and review that exposure going forward, but going backwards, it becomes a little more speculative on our part. Great question. So this is just unpacking those temporal changes over time by state here, as you can see. So we're looking at California, Florida, New York, and Texas. Again, we were fortunate to be able to publish this just 6 or 7 months into the pandemic, where we saw a very notable cyclic nature to exposures between weekdays and weekends prior to the pandemic. And for each of these states, you'll see we've got a baseline period, we've got a washout period in gray, and then we've got the intervention period when the lockdowns went into effect. And you can see for all 4 of these states, somewhere between March 11th and March 12th, despite the states having very different approaches to managing the pandemic, we saw this significant 3 or more decibel drop. And again, this is averaged across many, many people. So the lockdowns are effective at reducing COVID transmission and also effective at reducing noise. And so these are the same 4 states, but now projecting out as to what happened not immediately after the lockdown periods, but through almost the end of 2020 here. And you can see for some states, New York, for instance, exposure sort of sprang back pretty rapidly, while for other states like California, exposure stayed depressed over that entire period. Linda's asked, will I be doing a detailed analysis of exposure by people that failed the hearing test and include degrees of hearing loss? So we do ask people about previous diagnosed hearing loss, about perceived hearing loss. In terms of failed hearing tests, we, as with any hearing test, it's possible that people exceed the upper limit at which stimuli can be presented. So that's certainly one way that people can and do fail. Otherwise, for people who have poor hearing outcomes, but complete the test, of course, we're interested in associating that with noise exposures and with their perceptions of their hearing as well. And so Linda, that's maybe a natural transition to this slide. So 10% of our participants have reported having a diagnosis from a healthcare professional of a hearing loss. When we look at the tone audiometry data that we've collected, it's closer to 1 in 5 participants who actually show a hearing loss according to the WHO guidelines. So, excuse me, greater than or equal to a 20 decibel hearing thresholds across the average of 0.5 to 4 kilohertz. And we found that 7% of our participants have a hearing loss that's consistent with a noise-induced hearing loss. In other words, they have a 4,000 hertz notch. You know, from a hearing healthcare perspective, 44% of our participants haven't had their hearing tested in at least 10 years. So people aren't visiting the audiologist very often. And we know that about 1 in 4 of our participants experience tinnitus at least a few times per week. I'll also mention that in 2021, we introduced a new tinnitus matching task to try to help participants better identify the type of tinnitus, you know, pulsatile, whistling, etc., and match that. So we'll have much more detailed information on tinnitus to share in the future. So winding down here, the long-term goals of the study, as you've already intuited, are to characterize environmental noise and headphone audio exposures. We're also very excited to be employing machine learning techniques to identify sort of common exposure patterns, or maybe identify profiles of different types of exposure that might put people more or less at risk of hearing loss. We also want to evaluate, of course, the exposures and how they associate to hearing impacts. And again, we're doing that with tone audiometry, with speech and noise, as well as with some tinnitus outcomes. And I will say for all of these health analyses, we'll be doing that prospectively over time and controlling for the other risk factors that I mentioned earlier. We also, maybe to come back to Linda's question, we'll have an opportunity to evaluate more objective versus more subjective measures. So people's perceived hearing loss versus their measured hearing ability, and their perceived noise and music exposure compared to their actual exposures. And then again, to evaluate the impacts of our intervention on providing information. So if people are prompted to review their levels or to take surveys when they have noise exposures, are they perhaps likely to reduce or change their exposures over time? So a few more examples of things we hope to be able to do here. And again, we're doing these at the individual level rather than sort of in aggregate or by area, as has often been the case before. So we'll really, for the first time, be able to describe people's listening behaviors for headphone audio at multiple time scales, so daily, weekly, over the course of the entire study, and everything in between, and also understand their noise exposures from the environment at multiple time scales. We can also start to do some geographic analyses here. So understand, like I already showed you, are there differences locally or regionally or nationally between exposures? We can start to compare our measured exposures to estimates like you see here. This is from the DOT's National Transportation Noise Map. This estimates people's exposures due to transportation sources, and we can see, you know, how does that match to our actual measurements on people compared to these statistical predictions. And then for the industrial hygienist and me, we'll also be able to compare how much sound are people getting at work compared to what they give themselves through music, for instance. Very excited to be able to associate environmental noise and music to people's baseline hearing, to go back to that cumulative exposure question that we had, but also changes that they have in their hearing and their tinnitus, but also in their heart rate and their heart rate variability and their perceived stress. All of those things being very important outcomes of at least occupational noise, and we're extending this to the environment. And finally, evaluate once more these effects of our informational intervention to try to understand if basically your phone can help coach you and move you towards quieter exposure levels, which I hope to be the case. Justin's asked, given the nature of the study, I imagine there's a lot of missing data. That's absolutely right. And so we'll be using statistical techniques that can account for loss to follow-up, that can account for missing data. We're also employing these machine learning techniques to see what we can learn, perhaps, from people who systematically have missing data. So that's a great point, Justin. We're quite fortunate in this study that we're drowning in data already, but you bring up a great point. There may be other things where we don't have data that also warrant analysis. Susan's also asked, would commutes be considered occupational or personal time? So we do ask folks about time spent commuting, the assumption being that that's on your way to or from work. Now, people who drive a subway car or train for work, they're spending time on the subway, but that's for job. And so we'll be accounting for that with information about their job title. So just to wrap up here, I will mention some limitations. Several of you have already picked up on these. Of course, the exposures as well as the health outcomes we're observing may not be representative. This study is only comprised of volunteer Apple product users. And so that's going to limit us in ways that I've already described. But I will say that even if our data are not representative, they are still useful because there's basically nothing out there right now. So I'd rather take a step forward and acknowledge the limitations than just be so focused on the limitation of Apple users. So we will, of course, have to consider our limitations. We can do weighted analyses to try to match our sample to the broader population and will, in fact, do that. I'll also say for inclusivity, we have allowed people who aren't using Apple headphones to contribute their headphone audio data. That means we can get a lot more participants, but the data on non-Apple headphones are going to be less accurate. And we're going to account for this statistically, for instance, by comparing through sensitivity analyses. Well, what do our outcomes and exposures look like when we do restrict it only to Apple products versus when we include other potentially less accurate sources? We also know that those notifications that we can treat as part of our intervention can be silenced for participants, and we don't know if they do silence that. So that's going to potentially influence our results in that way. Moises has another question here, and I apologize if I'm butchering people's names. I'm certain I am, not intentionally. Can you use a proxy of cumulative exposure prior to the study? Right, so duration of exposure for a job is exactly the way we'll do that. So, you know, we ask people, how long have you worked in high noise at the baseline of the study? And that becomes our estimate, for instance, of cumulative exposure at baseline. All right, so in conclusion, again, we've got these three major knowledge gaps that we're addressing. We need to know more about exposures to environmental noise and music. We need to better understand those exposures' impacts on hearing, as well as their impacts on cardiovascular disease. This study is not the definitive crowdsourced science study, of course, but I'm hopeful that it's providing a template for how to assess these exposures and health outcomes at scale. And I will also highlight, though I never envisioned myself partnering with industry in my research career, I think this has been an incredibly fruitful and productive example of how researchers can benefit from partnering with manufacturers, for instance, who have access to technology that we simply couldn't develop as part of a small-scale research project. So Justin's got a question here. With the current devices available, can you envision a way to measure speech exposure versus simply sound exposure? So that's a great question, Justin. We could potentially do that through headphone audio. Again, we don't know what people are listening to, but we know broad categories. So we know a category of podcasts, for instance, which would just be spoken word. And so we could compare folks who have, 8 hours of podcast exposure to people who have 8 hours of music exposure and see if there's differences in their exposure levels and their hearing outcomes. It's a good question. And Pablo, any hypothesis on hearing loud music or sounds while exercising? Absolutely. So you may know there's some literature, limited, but some literature that suggests that people may crank up their music. I think spin classes are the example that's always given, where the instructor turns it up to 10 billion decibels as an effort to motivate or encourage people. But in reality, perhaps harming their hearing first and foremost. So we do have the ability to control for exercise. We know when people who use Apple Watches are exercising, and we can start to consider, do those folks who exercise more have better or worse hearing outcomes? So I think that's not quite the level of resolution that you're referring to, Pablo, but it is a question we have, absolutely. So I know I've gone a few minutes over, but I'm hoping in answering the questions as we went, it's sort of more timely and more enjoyable for you. Of course, I'm happy to take other questions right now. Before I do so, I want to thank you all for this opportunity to talk to you. I hope this has been somewhat educational. I do, of course, want to acknowledge that this research is funded by Apple through a grant to the University of Michigan. And I'll acknowledge my research team, Lauren Smith, Lingyan Wang, and myself, as well as the team of very talented partners that we have at Apple. If any of you are interested in learning more about the Apple Hearing Study, you can see the link there on the right-hand side. And if any of you are interested in participating in the study, I certainly welcome you to. And the way to do that is to download the research app through Apple. I'll point out this is not the only ongoing public study that Apple is funding. There are several others, all of which you can join through the research app. So again, thank you so much for your time. I think I will stop sharing my screen now and